Welcome to today's episode of the Medical Fitness Podcast, powered by the Medical Fitness Association and MRF Institute. My name is Thomas Hammett. I'm the Director of Operations for Pinnacle Lifestyle Medicine and the co-founder of the Medicine Rehab and Fitness Institute. And I'm co-hosting this episode today with my friend, Jeff Young, kinesiologist and co-founder of the Medicine Rehab and Fitness Institute.
Hey everyone, we're very excited to have on our show Dr. Laurie Whitsel. Laurie is the National Vice President of Policy Research and Translation at the American Heart Association and Senior Advisor for the Physical Activity Alliance. Laurie, thanks so much for taking the time to be a guest. Can you please share with our audience a little bit more about your background?
Sure, Jeff and Thomas, thanks so much for the opportunity to be with you today. It's what a great chance to have this discussion about all the work that we're doing together. As you said, I am the National Vice President of Policy Research for the American Heart Association. So in that role, I get to help translate science and evidence base into impactful public policy solutions that hopefully transform population health. We have advocacy reach at all levels of government at the American Heart Association, and we have a very wide and broad public policy agenda addressing heart and brain health. So it's really exciting to be, part of the work of that effort at our organization. And then I have the privilege of serving as senior advisor to the Physical Activity Alliance. So, we had this chance to bring the physical activity community together to speak with one voice on national policy and systems change. And we have 19 board level organizations that are doing the strategic leadership for the Alliance. And we have a number of key initiatives. We'll talk about one of those in particular today. And we have a memo of understanding with the Department of Health and Human Services to support the physical activity guidelines for Americans and Active People Healthy Nation, an initiative led by CDC. And so there's just so much opportunity to promote physical activity and help make it a part of everybody's daily lives.
Laurie, I'm just really excited that you're here joining us, and we'll get a chance to learn more about everything that you just mentioned. I was mentioning to you before the call, we just met, and my background's in physical therapy. I have a lot of conversations with medical professionals about referring their patients to exercise programs, and this is something you know a lot about. I'm curious, how are we doing on the whole in the United States at promoting increased physical activity and exercise in medicine?
Well, I'd say that we're making progress, but we still have, quite a ways to go in terms of making this a standard of care in the United States. As we work on the national policy and systems change, we're doing that under a campaign we're calling It's Time to Move. And it's really this effort to make physical activity assessment, prescription, referral part of the standard clinical workflow in the United States. And so that is a multi-year, multi-pronged effort involving numerous government agencies, quasi-government organizations, legislation in Congress, and payer community, et cetera. So it's going to be, we have kind of a runway of at least a decade for this work that we're doing, and we're really focused on the policy and systems changes that reduce barriers to making this happen. So we worked on, we can get into some of the details on some of the stuff we've been working on over the last couple of years, but some of the barriers involve, first of all, we need standardized measures in our electronic health records that allow for the assessment, prescription, and referral. So we've spent the last year and a half working with an organization called Health Level 7 International that does that measure standardization in the healthcare ecosystem. And we have, with an expert advisory group, developed an implementation guide where that can be put into electronic health records. And, so now we've got to work on implementation and uptake by health systems. And there are barriers there, in terms of where does physical activity integration fit within their strategic priorities? And it costs money to integrate this into clinical workflow. So how do we overcome those barriers? And how do we incentivize health systems, clinicians, and payers to make this a standard of care. So we're working in that space. And then we've got to pay for the exercise prescription. So that's going to take coverage determinations. And we need clinician champions to really make this happen. And so that's work that others have done as well, and others are leading, but making sure that clinicians feel comfortable having these conversations and referring their patients. And, and then finally, making sure that we're positioning qualified exercise professionals to be able to follow through on the prescription and ultimately be able to bill for their services. Right now, that's really tough because they're not recognized as the type of health professional who can do the direct billing. But we're going to work on that under national coverage determinations. And, as our health system continues to transition to value-based care, we really think there's the opportunity to embed qualified exercise professionals in that healthcare team that's helping people on their journey toward active living.
Yeah, what you just laid out could be literally the agenda of our entire podcast episode, I think, step by step, because I think all of our listeners would be really interested in learning more about each of those components. And we spoke with Amy Bantham specifically about kind of the work being done with the EMRs and creating those fields. You were talking about kind of step two being implementation and uptake, and I'm curious because this probably feels, if we have fitness professionals who are listeners, this feels like way up in the clouds kind of stuff, but probably stuff that's really interesting. I'm curious what does that implementation and uptake look like from the level that you're working at, or if you could give an example of how change is being implemented there.
Yeah, thanks for asking that question. So I think I would say in two ways we've been working on this. Three ways. Now that we've got our implementation guide done, we're literally talking to health systems about integrate, if they're willing to integrate it. And we're learning, where there is receptivity and where there is pushback. And I think, Thomas, what we're going to probably do is pull together a group of healthcare leaders, healthcare system leaders, to tell us, like, okay, these are the things we're thinking about that are barriers to us, and then we're going to think about ways to overcome those barriers. So that's one thing we want to do. We worked, and this is another heady thing that's up in the policy, wonk kind of clouds. But last year we worked with the Office of the National Coordinator to get physical activity assessment in what's called the U.S. Core Data for Interoperability. Woo, that's a lot of hefty words. But what that means is those are the basic core data that all electronic health records have to have in their systems. And so we were fortunate to get physical activity included as a health status assessment. Now, it's going to take a few years to get that fully integrated in federal regulation. But we have a goal. We're part of the second round of White House commitments. The White House has said, this is exciting. We see the progress you're making, are excited to take your commitment to have physical activity assessment in all electronic health records by 2028. So that's another way we're trying to foster implementation and uptake. Now, just because it's in the electronic health record doesn't mean it's part of clinical workflow. You've got to get clinicians and others to say, yeah, this is going to be part of my conversation with patients. So another thing we're doing right now is developing what's called a reference implementation. That's a mobile or web-based application that essentially allows qualified exercise professional, a patient, or a clinician to connect with a server, electronic health record server, and start to exchange patient information on physical activity, and essentially bring our implementation guide to life, make this all happen, help make it all happen. So we're going to be test driving that reference implementation this week at a Connectathon sponsored by the Centers for Medicare and Medicaid. And then we'll be continuing to refine it. And then we'll put it out into the public domain in the fall. So anybody can use it. Anybody can take it and use it and make it better. And so that's another way that we're trying to connect qualified professionals, qualified exercise professionals to this work we're doing, and make it feasible for them to communicate with clinicians, and be an option for patients, be there as a service for patients who need some help, need some support.
Yeah. Well, again, I really appreciate you sharing all that. And I think it's just so valuable to know that there's people going to bat at the big picture level for this at a policy level. And there's a lot of conversation, particularly amongst healthcare organizations and even just in the fitness world about this qualified healthcare professional movement. And to know that there's systemic change happening in medical systems that really supports that movement too it's really exciting. And I'm really thankful for the work you're doing to make that happen. I'm going to segue just a little bit because you wrote an article in 2020 with Amy Bantham and 3 others. I'm actually going to read the title in the journal because I think it's so important. The journal is Progress in Cardiovascular Diseases, and the journal article is titled Physical Activity Assessment, Prescription, and Referral in U.S. Healthcare. How do we make this a standard of clinical practice? I love this article. I use it as required reading for our clinical staff in the groups that I work for during onboarding. And I think it does a really fantastic job of outlining the ideal medical continuum to exercise, including members of the care team and best interventions for achieving a successful referral. The figures are also just great. I think it's really visually clear. Would you mind briefly summarizing the physical activity care continuum that you outline in this article for our listeners?
Sure, thanks, Thomas. And it's just so exciting to hear that this work we do is getting out there. And I would say that we've done a couple of follow-ups to this article too, where we've continued to learn. This has been a learning journey for me. Almost every day, I learn something new in terms of this policy systems change landscape. But in terms of that particular paper, what we tried to do was outline a care continuum where, the initial conversation happens, or first there's screening, right? And that screening can happen before you even arrive at your doctor's office, or your conversation with your nurse practitioner or physician assistant, where, in that initial screening that you do often online before you arrive, where you get asked about your tobacco use, your, any change in your conditions, and then what is your physical activity level. We have, incorporated in our implementation guide the opportunity to screen and assess for physical activity sometime during that clinician visit or prior to the visit. And then we want the conversation to happen when you're there as a follow-up to whatever information you provide. And then ideally, the clinician has resources at his or her fingertips to, if you're someone who needs a little support, maybe some supervised exercise therapy because of a particular condition, then there are opportunities to refer you to a community-based provider or resources in your community, recreational spaces, outdoor places. Sometimes patients just having the conversation is enough, and having their doctor say, what, physical activity could be a really important part of our treatment plan and care plan. And patients on their own could go out and decide to join the local walking club or, get that outdoor physical activity prescription. But then in other cases, because of a condition or because maybe they just need some help in terms of starting an exercise program, they might need a referral to a qualified exercise professional, somebody in the U.S. registry, certified exercise professionals. So, we'd like to see that happen and become a standard of care. And then ultimately, we want to have a feedback loop. So whatever's happened as a result of that referral and prescription, make sure the clinician knows, what was the outcome, and where, has there been improvement? Has there been follow through? So that's the continuum, the care continuum that we outlined in the paper. And we think that the referrer could be, physician assistant, nurse practitioner. And then there's, a really important role for physical therapists, occupational therapists, even athletic trainers to follow through, once they're working with patients after an injury or recovery, that maybe there's a secondary referral to a qualified exercise professional to do sustained, physical activity over time. And once again, that feedback loop. So that's what we outlined. And, that's what we're working toward in our policy and systems change to try to achieve that as kind of a normative standard of care.
Well, from a practice level, seeing the figure that you're speaking about with the providers and kind of where they lie in that continuum, and I think the language that's used in that article is physical therapists are kind of on this straddlers between the referrers of the
Mm.
medical providers and the receivers of the fitness nutrition world, and it just reinforced my reality so much as someone who was actively making referrals to exercise programs, particularly that when a recommendation had already been made by a physician, how much more impactful that was for me to be supporting and facilitating as someone with a little bit more time, who can build trust, who may have a better connection with the fitness program. There were so many things that, like, I just seeing that figure was like, oh, this is exactly what I feel.
That's great.
And yeah, it was just a really nice visualization of that for me.
Thank you. The American Physical Therapy Association is one of our board level organizations, and I just think there's such a critical role. And as you say, you're such a respected professional across the healthcare ecosystem, and you have such an important role. And we talk about making this a sustained behavior change, and you can truly help make that happen.
Yeah, I want to chime in here and say that in our recent episode with Amy Bantham, and I just want our listeners to know that we're recording here in July, so by the time that our listeners hear this, it'll probably be after August. But in August of 2024, there's going to be a special themed issue in the American College of Sports Medicine's Health and Fitness Journal titled Advocacy and Professionalization Within the Exercise Profession. And I was very fortunate to co-author a feature article with your colleague, Amy Bantham, and Dr. Matthew Campert from the Cleveland Clinic, uh, titled Developing Trusted Collaborative Relationships Between Healthcare Providers and Health and Fitness Professionals. So I just want the listeners to be aware of that as just another resource that they should go to, because as you know, Laurie, that this themed issue is going to give a really nice overview of what's going on, and what the PAA is driving. Another thing that I wanted to just mention, which will help tee up my next question for you, is just last week I was at the National Strength and Conditioning Association's annual conference in Baltimore, and I wrapped up a 3-year term as chair of what's called the Special Populations Special Interest Group. And just so you know, uh, I had a 50-minute presentation, and a lot of that presentation was actually on this. I had a whole bunch of slides on the QHP movement and we talk, and Thomas is on our executive council, and we have a LinkedIn group, we have a Facebook group, and we occasionally give updates, not only in our group, but in the NSCA's personal trainer group, etc. So we are absolutely out there letting people know what's going on, advocating for this. It's just, and again, just so excited that you and Laurie and your colleagues are leading this movement. It's just the most amazing thing. But that's going to lead into my next question. But I also want to tee this up for the listeners so that I'm not speaking jargon and they understand where I'm coming from here. There is a framework which you alluded to called NERF, um, which is an acronym that stands for the National Exercise Referral Framework. And it's being put into place to link qualified fitness professionals with healthcare providers through the electronic health record systems, or the EHRs, as you just mentioned. Specifically, within this framework, EHRs will be linked to a large database of fitness professionals called US Reps, which is another acronym that stands for the United States Registry of Exercise Professionals, to verify credentialed fit pros and create an easier mechanism to make the connection. When your colleague Amy Bantham was on our show recently, one of the things we talked about was the need to, and we also just kind of alluded to this recently, or minutes ago, I should say. We talked about the need, and for lack of a better word, the need to change the behavior of clinicians, similar to how we need to move patients through the stages of behavioral change. In other words, if clinicians don't become more motivated to refer their patients, the disconnect between our fields is going to remain a problem. Very briefly, two major healthcare or facilities that I worked at. Duke University Medical Center's Diet and Fitness Center was my first job out of college, and Mount Sinai Beth Israel Center for Health and Healing in New York City, where I'm at. And just just to give a quick visual, at Duke, the um, the pathway from the physician to the registered dietitian, behavioral specialist, fitness professional was built into the system. It was built in. And so because of that, the
Mhm.
model just really worked. And it was an amazing place, especially for me, the first job out of college. It was an amazing way for me to get that experience. And I just kind of assumed that's the way things were. Flash forward many years later, go to Mount Sinai, and I'm not picking on Mount Sinai on
Mhm.
purpose. But the truth is, we had 33 healthcare providers. We had family medicine, internal medicine, cardiology, physiatry, physical therapy. I can go on and on. But the truth is, we were a microcosm of what was really going on in the industry, in the sense it was different. It wasn't built into the system. So the point here is that I've experienced both sides of the fence, not just at these facilities, but others as well. And
Yeah.
so I understand, from a ground floor level standpoint, this need to change behavior. And again, we alluded to it minutes ago, but I'm curious from your standpoint, is there a plan in place to help, bridge this gap and to better inform clinicians to help create behavioral change so that we can ultimately make these connections to fitness professionals?
Yeah, this is at the heart of some of the things that we're working on, Jeff, because, well, two things. Medical fitness facilities offer a really great closed loop, and it's really a nice system where the referral can happen seamlessly, and the patient can, go to a center that, has been certified, and we've got a wonderful team there to support them on developing a personal, path toward, an exercise plan. And then the billing is all taken care of, as well. Or or the patient more likely is paying out of pocket for that service, right? Um, but when you have the average, and I don't mean average, and a clinician, who's let's just say a primary care physician in a community, it is confusing for them to think, who am I going to refer to? Yes, I'm having this conversation with my patient, but where am I referring them? So right now, qualified exercise professionals are not licensed, and we did an environmental scan of this whole field a couple of years ago because I needed to get my arms around this. It is a complex market driven field, in terms of certification, right? The numerous titles involved in for the qualified exercise professionals, and then the number of organizations that are certifying. And so I think the US registry of certified exercise professionals has been a really great resource for us. We embedded it into the implementation guide. We'd like to have it at the fingertips of clinicians across the country to know who they can confidently refer to in their community that has reached a certain level of certification. But honestly, Jeff, it would be more ideal, I think, for us to have a licensed professional in this space, who is the clear person that a physician or clinician could refer to. That's where the nutrition community has done it with the registered dietitian. It's really clear that they're licensed and they're who you refer to, and they can, be paid for their services. So that's something that we've got to work on. And in the meantime, though, I think with medical fitness centers, with our shift to value-based care, where qualified exercise professionals can be embedded within that healthcare team, as you were, I think, at Duke. It sounds like you may have been at Duke, where you weren't doing the direct billing, but you were part of a team that had a physician office or, hospital system, whatever clinic, doing the billing, but you were still able to provide your services, and those services could be covered. I think there are some really important interim steps we can take to create opportunities to make this referral more seamless. But we've got to keep working at it. And I think we've got to think about the coverage determination. I feel like we're going to have to approach CMS condition by condition for now, where I think we've got growing evidence on the role of physical activity supervised exercise therapy, I should say, for cancer treatment, for depression, and for fall risk reduction in older adults. And so, could we use the current infrastructure we have? Um, like we were able to get supervised exercise therapy for patients with peripheral artery disease. Most of those patients go through the existing cardiac rehab infrastructure we have, right? Um, could we continue to build that out for other conditions and other diseases, or other treatments that's evidence based? That's kind of the approach I'm thinking right now, um, versus trying to get coverage for exercise and referral into a community-based provider. There are a lot of barriers and roadblocks to that right now, as been evidenced by our implementation of diabetes prevention program. It hasn't unfortunately gone as smoothly as we would have liked, because that was the first community-based prevention program that was going to get paid for by CMS, and that was opening up the door to being able to offer preventive services in the community. And we just have to try to get this better. We've got to keep working with both private and public payers to continue to pilot and model. And we've got to show ultimately return on investment, cost effectiveness of this therapy. When you talk to the payer community, they have to know that they're going to be saving money by paying for supervised exercise therapy. And we can be upset about that, but that's just the reality. And so we have to keep building that evidence base.
Thomas, I would love to hear what you had to say on this, since this is entering your world. Um,
Yeah, you just have to think of non-traditional ways of reimbursement for this and who's willing to pay for what Laurie was talking about. It's uh, if you think about the physical therapy fee-for-service model, there's a ton of administrative work. So it's almost like be careful what you wish for in insurance-based model, right? Particularly when it comes to prevention. Somebody has to find it valuable enough to pay for it, and pay for it at the level that the person getting paid thinks it's enough money to be paid, right? So
That's right. That's right.
so if Jeff gets paid $20 an hour by Medicare, that may not cover Jeff's bills. He's probably not going to opt into an insurance-based system. In the physical therapy world, a lot of what's working from a prevention standpoint is looking at employers, and big employers in particular, because workplaces are really invested in not letting their employees get hurt. It's a tremendous financial loss to those organizations to have people out. And there's financial incentive to keep their employees healthy, which is where, Boeing up here in the Northwest has a work fitness program that I would call innovative, but implemented at a level that clearly they're not fitness professionals running the thing, right? So there's room for improvement would be my feedback to them. But it's tricky. It's a really tricky, and I think some of it is looking into the future. It's hard to know how much is CMS or our other payers going to value this exercise service. If it reflects cardiac rehab in a hospital-based setting, that's been pretty good. I'd say it's worth it for us to develop exercise programs for other conditions beyond cardiac pulmonary conditions, because you might get paid enough money to make that valuable to do. If it's not as much as that, or if reimbursement continues to decline like it has in physical therapy, unfortunately, it's tricky to say whether that's the right place to stack all of your chips, but it's a good place to stack some, and it's definitely the way that we should be thinking in terms of integration. So I don't know. Those are my 2 cents on the QHP movement and thinking about the insurance pay model. It's tough, but it's really good. And what I loved hearing you say, Laurie, is you're going condition by condition, to see, kind of thinking about how an exercise service may be covered for those conditions. And it's probably what needs to be done. So it's really interesting to hear that that's what's happening, and important work for sure.
The Medical Fitness Podcast is brought to you in part by the Medical Fitness Association. Attention all medical fitness professionals, get ready for the event of the year. Register today for the Medical Fitness Association Annual Conference, November 19th through the 21st in New Orleans. Network with industry experts and like-minded professionals from around the U.S. and Canada. Gain insights from leading voices in medical fitness and take your career to the next level. Don't miss out on this incredible opportunity. Mark your calendars for November 19 to 21st and join us in New Orleans for the Medical Fitness Association Annual Conference. Register now at medicalfitness.org. That's medicalfitness.org.
Thanks, Thomas. I think you're right in that we have to think about all kinds of models for how to support people. As you say, on the prevention side, a lot of people will pay out of pocket for their
Yeah.
exercise program, right? And we're reading a lot about this generation, right? That younger generation that's willing to make this investment in their health and really excited about it. I was reading an article the other day that some are spending up to 10% of their income on their yoga or other exercise classes or their memberships, gym memberships. And that's wonderful. It's great that this generation, my children's, generation are really thinking about this toward their health and well-being and investing in that. But as I read that article, I got thinking, yeah, but there are many who can't afford to make that commitment and that investment, right? And so what we don't want to do is increase disparity by saying, yeah, we might be able to do a lot of this by just paying out of pocket. We've got to look for ways to make sure that everybody can access these services. And so is it community level scholarship programs, as you say, employer benefit, the benefit package, benefit design that employers are offering across all occupations and jobs. The intersection with the employer-sponsored health insurance and employer marketplace is really critical and one we're thinking about as well.
I am going to, even though again, in our conversation, we've kind of touched on some of this stuff. I have a semi-related question to ask you. I sit in a Facebook group that's mostly for the Obesity Medicine Association. And I actually just presented at their annual conference in Denver several months ago. And there's about 7,000 people in this Facebook community. And needless to say, the majority of them are primary care providers and NPs, PAs, allied health, professionals. And I see the chatter going. And recently, one of the primary care providers posted a link to a PDF that was from a recent publication of the American Academy of Family Physicians. It was actually a practice manual. So that's what the PDF was. It was a practice manual to address health disparities for people with obesity. And surprisingly, it left out the role of the exercise specialist, or maybe not so surprisingly, as a member of the collaborative care team. So the team members that were included in this article or this paper were registered dietitians, psychologists, physical therapists, and of course, physicians. So I'm curious, do these articles or articles like this damage efforts of groups like the Physical Activity Alliance who are working hard to try to include exercise professionals as recognized members of these care teams?
I just think, Jeff, it's a continued conversation, and they may, I don't know for sure because I haven't read that article, but if they, or that manual, but if they were thinking about this from a billing perspective, that might make sense, that the qualified exercise professional wasn't in that group because, in the CPT codes with the American Medical Association, qualified exercise professionals are not in the category of generally in the category of people who can bill for their services. So that's just the reality right now that we need to change over time. But I also think, just making, one thing I've tried to really advocate for amongst all of our leadership organizations and all of those in the field right now is that we move outside of the physical activity community to talk to people who um, we wouldn't normally be having conversations with about the importance of physical activity promotion. Get in front of those medical conventions, those professional membership organizations. In the past year, I've been talking to health information technology professionals who understand when you tell them the story of physical activity and what we're trying to do, they understand why this is so important. But they just, it's just not a group that we've talked to previously, right? So I think we're all obligated, those of us who are in the space are obligated to find one or two meetings, conferences, events to get in front of. And sometimes those conversations are uncomfortable. They're like, "Who are you? Why are you here?" Um, but let's get qualified exercise professionals into those conversations and just introduce them to the work we're doing and hopefully get invited to their tables. And that helps us move all this work forward. But it's just, I think, our obligation to continue to advocate and position and do our own work to get that clearly identified exercise professional that should be part of the healthcare team, that should be, the person who can be that resource for, and then the clinicians feel comfortable referring to. So there's a lot of work to do, but I think I'm up for continuing to do the work, and I'm not discouraged by that, Jeff. But I say let's just go out and you know maybe have a conversation with AAFP and see where they are in their work, and if there's a role for us collaborating and coordinating and inviting them to some of the policy and systems changes we're working on.
That note, actually, Dr. Andrew Mock, who I believe Mike Stack, you know Dr. Mock?
Yes.
Yeah,
Yeah.
so he's also a friend and colleague of mine. Mike and I presented last year at the ACLM's annual conference, and then we're doing it again this fall. And so knock on wood, I know that he's trying to get um, some sessions going within the AAFP, the American Academy of Family.
Oh, that's beautiful. That's great.
Yeah. So yeah, and Thomas, do you have anything to chime in? I do have one more question that I want to ask that will kind of relate after Laurie answers it. It might relate back to this whole billing thing, but I wanted to ask if you had anything to chime in with first. No? Okay. So my last question for you, Laurie, is, I'm closing in on 30 years of experience as a fitness coordinator and a coach, primarily in clinical settings. Has been Duke, UCLA, Beth Israel, and Mount Sinai. And so, I'm fully aware that the primary reason why patients seek out services of fitness professionals, for the most part, there's always outliers, is for the strength training component. In other words, they don't pay us to talk to them while they're walking on a treadmill or riding a bike. There's so much underappreciation, underutilization, and even underdosing of strength programs, especially among older adults and people with chronic conditions. As a matter of fact, as the outgoing chair of the National Strength and Conditioning Association Special Populations Group, this was really the theme of our group, that we got to stop with the underdosing, and we got to stop being afraid of strength training and uh, words like progression and intensity and things like that. So as we mentioned before, I met you several years ago through the Physical Activity Alliance Assessment, Prescription, and Referral Working Group. And without going into too much detail, but so our listeners can be informed on this working group is, as you have already talked about, is helping to lead the efforts to connect clinicians with fitness professionals. And so I'm curious, with that as a background, is part of the goal or vision of this working group? Like, my understanding, correct me if I'm wrong, is that there's kind of two prongs with this working group. First is the policy change, which is what you're been working hard on for the last 3 or 4 years, and that's going extremely well. Once we get the EHR standardized and connections to the physical activity vital sign, which is already going to be implemented, and the connection to US reps, then things, in my understanding, are going to start to shift over to more a little bit of at the ground floor level. And so, since at the ground floor, patients are mostly being referred for strength training, I'm just curious if this working group is going to create more awareness of the importance of progressive strength training and help make these connections between physicians and fitness professionals for that purpose.
Thanks for that question, Jeff. So I think that resistance training, strength training is an underappreciated aspect of our physical activity recommendations in the United States and across the world, right? So we talk about the physical activity guidelines for Americans, and most often it's the 150 minutes of moderate to vigorous physical activity per week that is cited as key recommendation. But we forget to say, and at least 2 days a week of muscle strengthening exercise, right? And so I got an appreciation for that as we were doing this work and measure standardization. So that core assessment that I talked about for physical activity and electronic health records, we actually have the muscle strengthening question in there, as well as the moderate minutes of moderate to vigorous physical activity, i.e., the exercise vital sign questions, as well as the question that's from N. Haynes on muscle strengthening. That captures the full recommendations of the physical activity guidelines, and it's really important. Just a couple of weeks ago, the U.S. Preventive Services Task Force put out a level B recommendation on the importance of supervised exercise therapy, strength training for older adults to prevent fall risk, right? To reduce risk of fall. That's just one example where muscle strengthening exercise is so vitally important across the lifespan, on bone integrity, on muscle mass, on fall risk reduction. It is just so, so important. And so I think I only know, honestly, of one health system that is currently including muscle strengthening in their physical activity assessment of patients. All the leading health systems that are doing physical activity assessment most often are doing the physical activity vital sign or the exercise vital sign. And so we're missing those data on muscle strengthening. I think that's so we've got to, as we talk about getting core measures into the EHR, we've got to have muscle strengthening included. As you say, it's got to be part of the follow through, right? So once the referral happens, hopefully that becomes part of the individually tailored plan that the qualified exercise professional is working, on with the patient. And I would say this, that the reason for getting this into a standard of care in the U.S. health system, I think, serves three purposes. One, obviously, it's most important for patient health and well-being, right? Incorporating physical activity into our daily lives. But it's also a supplement to our national surveillance systems. CDC is really excited about this work that we're doing because having data in electronic health records supplements what we know about how people move throughout the day in the United States. We've got several national surveillance systems, but there are gaps in those systems. And so the example that we like to use is, during COVID, Kaiser has been collecting aerobic physical activity data for their patients for years now. And they were able to go into their EHR database and see that patients who are more physically active were having better outcomes from COVID. And so they published a paper in the peer-reviewed literature, and CDC was able to use that evidence and other evidence that they were gathering to change public health guidance in the midst of the pandemic. That's incredibly powerful, right? So it supplements our national surveillance systems. And third, it provides us the opportunity to have a better understanding through research of the relationship between physical activity and, all the aspects of health, mental and physical health. So this is why this work is so important. It's for patient care, but it's also so we have a better understanding of the role of physical activity in health and well-being. And so muscle strengthening is a big part of that. It's our obligation in the context of all this policy and systems change work we're doing to make sure that it's included and try to put it front and center for people. And as you say, try to reduce some people are scared about going into the gym and thinking about, lifting weights and doing resistance training. We've got to try to help overcome that and make it inviting and welcoming and inclusive and just a part of the exercise prescription overall.
That's what Mike and Andrew and I are doing with our workshops.
Excellent.
It's 3 hour pre-conference workshops where we have like 1 hour of lecture and then 2 hours where we're actually taking the attendees through the exercises and really trying to do exactly what you just said. Dispelling this whole myth that we have to be worried about those things. But I know we're getting a little low on time, so I'm going to turn this over to Thomas.
Yeah,
Okay.
I want to ask one very quick question based off of what you were just sharing, because I'm curious. The Kaiser data that you referenced it's the physical activity vital sign data, correct?
They use the exercise vital sign, yep. And it's minutes
yeah.
with moderate to vigorous physical activity per week, yeah.
What I'm curious about is, I think self-reporting data is, and it's so important, right? Like what you guys are doing in terms of integrating that in EHRs across the country is incredible. I'm curious if you see a future where we go beyond self-reporting and there are, I don't know, some way to get a tracking, and I don't know if we call this remote monitoring or what we would exactly call it, but if you have a vision for that, if that is somewhere in the future and what that might look like.
Totally. Thomas, thanks for asking that question. That would fall under remote patient monitoring, but most importantly, our current funder for this work in HL7, it was critical for him that we could accommodate the device-based measurement of physical activity. So in addition to, so we were accommodating in our implementation guide that your assessment, your physical activity assessment could come from self-report, or it could also come because you connected your iPhone to your electronic health record, and that data could be passed into your EHR. So it could happen either way, and I think that's a really powerful opportunity for physical activity, Thomas. And I think it will be part of the next physical activity guidelines, kind of us understanding the digital health ecosystem and the role that devices can play in helping to capture physical activity across the population. It's not perfect yet, and there's still, there's differences across devices and within devices, um, but I think it's an opportunity for us to be even more objective in our capture of physical activity, understanding how people move across the 24-hour cycle. That's the other thing about our surveillance systems. Most of them are just capturing leisure time, what we do in leisure time. But we can't forget about what people do at work, what people do in active transport to and from work or to and from school, and then what they do around the house, like household physical activity too. So there are 4 different domains for our physical activity. And ideally we have, the devices allow us to capture across all those domains. So there's a lot more we need to understand about, and also the interrelationship. Like if you have a lot of heavy physical activity at work, what does that mean for your leisure time physical activity? And how do people balance that across their day? So countries are starting to think about this in relationship to the 24-hour day. And I think, we're going to start to think about it that way. And I'm interested to see how this is all handled in the next physical activity guidelines. We're talking about all this in the context of the next revision and update, and what areas of science are going to be reviewed in this go around.
That's really exciting to hear. I think, like you're saying, there's so many gaps that can be filled just by seeing that monitoring data and asking the right questions, and just super exciting to think about the future of what we can learn to improve people's healths. Laurie, thank you so much for your time today. Do you mind kind of sharing with our listeners before we wrap up where people can reach you or learn more about the work you're doing?
Oh, thanks. And I would, feel free to reach out anytime. I would say that the Physical Activity Alliance is most active on LinkedIn. So reach out to us there. You can reach out to me personally on LinkedIn as well. Or my email address at the American Heart Association is laurie.whitsel@heart.org. So any one of those ways would be great. And just grateful for anybody who wants to join our movement, our effort. And thanks so much for the opportunity to be with you today.
Yeah, we'll make sure to include some of that in the show notes. And Laurie, truly a pleasure. Really incredible information you gave us today. And hopefully our listeners can take away some things that they didn't hear before. So thanks so much, Laurie. It's been great having you, and look forward to future conversations with you.
Thanks, Thomas. Thanks, Jeff.
Thank you so much.
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.